Hi guys, my name's Alan F1 in Mid Yorkshire Trust. Before we start, just to apologise, I'm actually supposed to be doing this talk with another F1 James show, but he's still at work, so he's not going to be here at all. So we were supposed to do GI and a GI history and examination, but we're just going to do the examination part. I do apologise for that. Unfortunately, my part's only 20 minutes as well. James's was 40, so it's going to be short as well. In terms of GI examination, I'm not just going to talk you through how to do a GI examination, because I think you all clearly know how to do that, and you can do that quite confidently. So what I thought would be more beneficial for you guys would be to talk about what signs to look for and what things to potentially say in your OSCE when you find patients with specific pathology. So this slide is just taken directly from the Ask Dr. Park website, which I advise you to look at if you haven't already. So this is what has come up in the past in terms of abdominal examination. You can see that the same thing comes up over and over again, really. And it's all quite straightforward stuff. The ones in red are what I plan on talking about today, going through today. So renal transplant, what signs to look for in a renal transplant patient, what to do if you see a patient with a stoma, and also inguinal hernias, which has come up twice before. Don't know how likely it is to come up again, but it's better to be fully prepared, I suppose. Okay, so renal transplant patient, which has come up pretty much every year according to that past slide. In your exam, you'll all do it in different places, so you can pretty much guarantee one of the circuits is going to have a renal transplantation on it. When you go into your station, and it's an abdominal examination or a GI examination, obviously look for all the things you normally look for in a GI exam, like signs of chronic liver disease. But bearing in mind this is with the OSCE and you're probably expecting a renal transplant patient, be aware of the signs of chronic kidney disease as well. So on general inspection of a patient who has a renal transplant, what sort of things are you looking for? Sorry?
Scar?
Yeah, that's got on more general, so we haven't even uncovered the abdomen.
Fistula?
Say she's wearing like a long sleeve gown. Yeah, okay then. So you'd see a fistula. More general than that? Someone who has chronic kidney disease?
Edematous?
Yeah, there'd be edematous. They might be short of breath due to pulmonary edema. That's one thing to look for. Anything else? No? Are you all shy or you don't know the answer?
Underweight?
Sorry?
Like underweight? Maybe.
Potentially, yeah, potentially.
Someone with a Cushing group?
Excellent, yeah. So these are things to look for. So what the books describes as salad complexion, that's basically a kind of yellowish tinge to the skin due to anemia, so that's pallor due to anemia, and also uremia, which causes kind of a yellowy tinge. And you can tell they're yellow, but you don't think it's jaundice because it doesn't really look like jaundice. I can't explain it any better than that. You have to see the patients really. I'm sure some of you must have done the renal placement in fifth year, so make sure you've seen transplant patients. So patients who have chronic kidney disease and uremia are pruritic, so they itch a lot, so look for excoriations over the body. We've already said breathlessness due to pulmonary edema and peripheral edema. You could look for the peripheral edema at the beginning or the end, entirely up to you guys. Bruising, chronic kidney disease patients bruise easily. And corticosteroids, so patients who have had a transplant are on a cocktail of immunosuppressant drugs, one of them being prednisolone. So look for their central obesity, look for bruising, because it looked like they've been using steroids for a long time basically. Another thing to look for is squamous cell carcinoma. So the renal transplant patients we have in Dewsbury, they sometimes come and they're covered in these wart-like lesions, which I didn't know what they were at first, but they're actually squamous cell carcinomas, so look for that, it's relatively common. So we've done general inspection.
Sorry, why is it common?
Because patients who are on immunosuppressive drugs are more likely to develop malignancies, specifically squamous cell carcinoma and blood malignancies. Yeah. So moving on to the hands, what would you look for in the hands for in a transplant patient or a kidney disease patient? On top of the stuff you normally look for, like chronic liver disease.
Signs of anemia?
Yeah. Yeah, so in the hands it's just the usual palmar creases, look for pallor in the palmar creases. And apparently patients with chronic kidney disease get brown tips on the brown discoloration of the nail tips. Never seen it myself, but that's what people have said. That's pretty much it in the hands, but obviously look for all the other stuff you look for. So moving to the arms, someone's already said you'll see the AV fistula. So when you see the fistula, what do you need to do? Do you just look at it and move on, or would you do something? It's kind of a leading question.
Check the roots and then check it's working.
Can't hear what you're saying, sorry.
So you check for erythema, any edema, but it's actually pulsating, and that's what it's looking for.
Yeah. So when you see the fistula, first of all, note where it is. Is it in the wrist or is it in the antecubital fossa? So in the wrist, yeah.
Do you have a picture? I haven't seen one.
Oh, I'm so sorry. I have to apologise. I did this presentation during my night shift last night, so it's a bit bland. But I'll put when I send the slides to Shana, I'll put some pictures in. Okay. You need to go to the renal wards as well and actually examine one of these patients before you go to yours. Yeah. So you've seen a fistula. Describe where it is. If it's in the wrist, it's radiocephalic. If it's in the antecubital fossa, it's brachiocephalic fistula. You need to palpate it. So you should feel a continuous thrill. Just when I say palpate, just put your hand on top of the anastomosis and you'll feel a continuous thrill. Quickly listen to it with your stethoscope, you'll hear a continuous murmur. So a continuous murmur and a palpable thrill indicates that the fistula is healthy and working. Okay? That's pretty much it. That'll take like 5 seconds. Face and eyes and mouth, etc. So around the eyes, look for any periorbital edema, for fluid retention again. Look in the conjunctiva for any pallor. In the mouth, I've written halitosis. I'm not sure why patients with chronic disease, kidney disease get halitosis, to be honest. But gum hypertrophy is another one to look for. I think about 40% of patients on cyclosporin have gingival hyperplasia, and they have really big gums. It's quite obvious, so just have a quick look at the gums to see if these patients have been on cyclosporin. Mycophenolate shouldn't be there, so I'll make sure that's not on the slide when I send it. So in the neck, guys, what do you look for in the neck?
JVP, raised.
Yeah, JVP. Anything else?
Lymph nodes.
Sorry?
Lymph nodes and raised lymph nodes.
Lymph nodes. Why lymph nodes? Oh, well, you do it anyway for your GI, yeah, because it's a GI examination. So you would be lymph nodes. But specifically for a transplant patient.
Any other access?
Yeah, excellent. Did you see it, or did you know?
No.
Yeah, so look for any vascular access scars in the infraclavicular region. They might have had emergency dialysis before, or just dialysis before they had the fistula fashioned. What else in the neck? Patients who have the transplant have often had a parathyroidectomy as well, so look for the parathyroidectomy scar from kidney disease they get to secondary or tertiary hypoparathyroidism, or renal osteodystrophy, whatever you call it, and they have the parathyroid glands. Yeah. So we get to the abdomen. Inspection of the abdomen. What do you guys look for? Related to kidneys and not GI.
Masses?
Yeah, so you might see a mass, the kidney, one of the iliac fossa, usually the right. You don't always see it, especially if the patient is quite large. If you do see the mass, if you want to look slick, you can ask them to lift their head off the bed. So lie them flat and ask them just to lift their head off the bed. If that mass is in the abdominal wall, it'll become accentuated. If it's within the abdominal cavity itself, like a kidney would be, when they lift their head up, it won't change in size, or even maybe disappear. Look for the overlying scar. The scar is called a hockey stick scar or a Rutherford Morrison scar. Whenever you see a scar on the abdomen, a surgical scar on the abdomen, ask the patient to cough, just to show to the examiner that you're aware of the potential complications of scars like hernias, basically incisional hernia. So ask the patient to cough. Unlikely to get an incisional hernia through transplant scar. Look for any other scars on the sides and around the back for nephrectomy scars. They might have had their kidney out. Often they don't take the kidneys out. They leave them in place for two reasons really. The first one is it makes a complicated operation even more risky. And the second reason is the diseased kidney actually has some residual function, so you leave it in place anyway. Yeah, look for small port scars around the umbilicus, which may suggest they've had peritoneal dialysis in the past. So it's a catheter scar, a bit like the laparoscopic port scars. Then examine the abdomen as you normally would, palpation, auscultation, cushion, and everything. I've written there, don't forget to palpate for the native kidneys. If they've had a transplant for polycystic kidneys, you will be able to block the kidneys. And then when you come to palpating the mass, the kidney, be gentle when you do it because patients are very protective and precious about their transplanted kidney, understandably. And then just describe the mass as you describe any mass, really. So where is it? What size is it? What's the surface feel like? Is it firm? Is it modulated, etc., etc.? You know how to describe the mass. Yeah.
So whereabouts do you feel the transplant kidney? Where
You'd feel it in one of the iliac fossa. It's usually on the right.
in the iliac fossa?
Yeah. You won't miss it if you have a good feeling. You can't miss it.
So just we haven't done renal
Have you
yet,
not?
so we like.
All right.
Like
It's
an
literally a
process.
kidney here. You can't miss it if you feel it. It's quite superficial, so you will feel it. Go to the renal wards and actually feel them. This slide is just differential diagnosis from mass in the iliac fossa. Basically, if they ask you for a differential diagnosis, here it is. Split it up logically, so mass is in the right, mass is in the left, then I split it up GI, gynae and other causes. You might do it other ways, but don't just blurt out a load of random answers, try to think about it logically. If it's a kidney, it's pretty obvious then. Okay. Any questions on that bit? No? You can all do a good examination.
Where's the scar for where they put it in?
It's right over the kidney, it's like an L-shaped scar, that's why it's called a hockey stick scar.
And would you be expected to talk about if the patient's saying I've had a transplant, or will they not
Well,
say
that's
that?
perfect.
But surely it seems a bit silly to start listing these differential diagnoses.
Oh, well, yeah, if they've told, you, okay, I don't think they will tell you.
Okay.
But if the examiner asks you for a differential,
I see. Yeah.
you see what I mean? You need to summarise. I'm sure you all know how to summarise. I'm not going to go over that again because I think they told you in your previous respiratory and cardio lectures. So summarise in exactly the same way. Just a tip for you. In my exam, during the examinations, I didn't actually say a word. I just spoke to the patient and just did the examination, expecting to present it at the end. But not one of the examiners wanted me to present or summarise. They just literally said, no, move on and threw me an ECG or something like that. So, personally, I think it's better to not talk during the examination and talk to the patient instead. But you guys can make your own mind up. I think it's a bit thirdier to say everything you mentioned, you're looking for. Yeah. Any other questions on that bit? No. Okay, so hernia examinations. Have you all examined a hernia? Yeah. One person has at least. Okay. I don't know how likely it is to come up, to be honest. It's come up twice before. I don't see why it couldn't come up because there's millions of people walking around with hernias, so it's not hard to find a hernia patient. The best place to examine a hernia, if you wanted to, would be to go to the day case surgery because hernias don't normally come to the wards unless they're strangulated or something. We're going to talk specifically about groin hernias. This is the only slide of anatomy, don't worry. The only important bit in this slide is actually the middle bullet point. So to examine the hernia, you need to know where the deep inguinal ring is. So that's midway between the anterior superior iliac spine and the pubic tubercle, which is there. Not to be confused with the mid-inguinal point, which is the femoral artery. Okay. In the exam, if you do get a hernia, you've obviously done your GI examination as you always do, and then you've noticed this lump. Don't spend ages examining the hernia. It's not like the MRCS or anything. Just literally 20, 30 seconds to examine the hernia. Okay. So do you guys know how to examine a hernia? Can someone tell me? You've done it.
Well, you obviously do your normal examination,
Yeah.
and then you can either stand the patient up and examine it initially, or you can kind of ask them to cough first and see if you see something come out,
Yeah.
and then put your hand over kind of the now I'm sort of mixed it up, but the
Don't worry.
inguinal to basically obliterate it if you can reduce it, and then get them to cough so that you know whether it's indirect or direct.
Yeah, that's more or less what you do. So you need to make sure the patient's adequately exposed first, obviously. Ideally, you'd want to see the external genitalia, but in the OSCE, probably not. Make sure you can at least see the suprainguinal region or the inguinal region. Okay. Even though you'll have asked them about pain at the beginning of the examination, ask them again specifically whether the lump is painful, because the last thing you want to do is start pressing on the lump and cause the patient pain. Yeah, and as you said, you want to examine them lying and standing. In the OSCE, they'll be lying down already, so I would just examine them lying and say, ideally, I'd like to examine them standing. In practice, you do it standing because sometimes when patients lie down, the hernia automatically reduces, so you don't know they've got a hernia. Yeah. So the first thing you want to do is look at the lump properly. Everything you need to do is pretty much on there, so describe where it is basically. Make sure you look at both sides because bilateral hernias are very, very common. Look at the colour and the health of the surrounding skin. Is there an indication that this hernia might be obstructed or strangulated? Surrounding scars, so scars around the hernia suggest that the hernia is actually associated with previous surgery. And ask the patient to cough at this point. So after you've inspected the hernia or the lump, ask them to cough and look for a visible cough impulse first. So you guys know which hernia or which lump will have a cough impulse?
Inguinal.
Yeah, both of them
Both
have
normally
a...
would. Yeah, doesn't.
So inguinal hernias basically. So that's looking for a visible cough impulse. Okay, so then you want to palpate the mass. Again, palpate it gently. Describe the mass like you describe any mass. So first of all, is it painful? What's the surface like? What's the consistency like? Is it fluctuant? And the temperature basically, and the borders. If you can get above the hernia, then it's not a hernia basically. It's something else because you can't get above a hernia. Does that make sense? So then you want to feel for a palpable cough impulse. It's more important than the visible cough impulse, to be honest. So just place the palm of your hand over the lump, ask them to cough. If there is a cough impulse, the hernia will tense and it will become enlarged. So that's the sign of an inguinal hernia. If there's no cough impulse, that means it's an inguinal hernia that is incarcerated or obstructed or strangulated, or it's, well, a femoral hernia might have an impulse. If it doesn't have an impulse, it's not a hernia. Okay. So inspection palpation, you want to then see if you can control the hernia. First of all, if it's reducible, and secondly, if you can control it. So ask the patient if they can make the hernia go away. If they can reduce it themselves, get them to reduce it, because it's sometimes a little bit painful. If they can't reduce the hernia, gently try yourself. So just try to push it back into the abdominal cavity. Even if you've never done it before, it's quite easy to shove it back into the abdominal cavity. That's when you need to find the deep inguinal ring. So 2 fingers halfway between the anterior superior iliac spine and the pubic tubercle. Firmly press down, ask the patient to cough. If the hernia comes out, it is a...
Comes out, it's direct.
Or a femoral hernia. Yeah? If it doesn't come out, it's an indirect hernia. Okay? It's quite difficult to do sometimes. So operation is the only way to actually tell between the different types of hernias. I'll put this bit in a bit of a bracket at the bottom. I don't know if you can see it all. The books tell you to auscultate and percuss over the hernia to see if there's vowel sounds or resonant percussion. I've never seen anyone do that in practice. I've never done it in practice. I'm not sure how much it would add, to be honest with you. The best way to tell if a hernia has got bowel loops in it is to actually reduce it. When you reduce it, if you hear gurgling sounds, then it's got bowels in it. If there's no gurgling sounds, then it's probably a mental. It's got a mental sleep. Differential. Again, split it up logically. I've just written here the differential diagnosis for a mass in the inguinal canal, not for a mass in the scrotum, but make sure you know the differential for a mass in the scrotum as well. Okay. Is that clear, or have I just confused you? Or did you already know?
You know what you said about the visible pulsation being connected to the inguinal? Why is it not femoral? Because the femoral is obviously really close to the artery.
the answer to that you'll have to ask a general surgeon, sorry. I don't know.
But if you ask
You-
it
you-
on the blog, you'll respond.
Yeah, all that. Or you can Google it yourself. Femoral hernias can have a coffin pulse, but they don't all have a coffin pulse. I don't know the reason.
I thought they normally don't because the hole's tighter. I was in clinic this afternoon.
Oh, right.
The hole's tighter, so therefore, like when you cough, it's too tight to force more of it through.
I mean,
And you can't reduce it because again the hole's too tight.
right.
And because the hole's tighter, it's more likely to strangulate, so you like have to operate on them.
Yeah. I agree with what you're saying. If the surgeon's told you that, clearly they're correct. But
But
I
that-
know some femoral hernias do have a coffin pulse, but that's not. Okay, but yeah, I agree. So any other questions on hernias? Nope. Excellent. So just to reiterate, if you do get a hernia, that took a while to explain, but it only takes 15 to 20 seconds to actually examine it. So it's not like adding loads onto to your examination that you've already done. And the important thing to remember is, in fifth year, you just need to do the basics really, really well. So make sure before you examine the hernia, you've done a really good GI examination. Okay? And don't get caught up on examining the hernia too much. Moving on to stomas. If you get a patient with a stoma in your examination, then you should count your lucky stars really, because you're not going to miss that. When I say examine the stoma, you're really just inspecting it. It'll take about 10 seconds to inspect the stoma. So if you do see a stoma, what do you guys look for? Or what questions you want to answer in your own head?
You want to know like where it is and what is coming out of it and the consistency of it.
Yeah. Yeah. So if you see a stoma, the three questions you need to ask yourself are, what is it? Is it a colostomy or an ileostomy? Or alternatively a urostomy, but that's pretty obvious, it's got urine in the bag. Is it functioning and is it healthy? So there are three things you want to ask. That's a little bit rude, isn't it? So the first thing to do is note where it is. If it's on the right hand side of the abdomen, it's a, someone shout. It's probably an ileostomy, yeah. If it's on the left, it's probably a colostomy. So you've noted where it is. The next thing you want to look at is the contents of the bag. So the contents of an ileostomy bag, what would that look like? Or, yeah, it's like a greeny liquid. Greeny liquid. And a colostomy is the opposite. It's like semi-formed stools, brown, poo, basically. Look for blood in the bag and look for any mucus in the bag. Blood is abnormal, obviously. Mucus can be normal in a stoma bag. So next, look at the stoma itself. So look at the mucosa itself. If the mucosa is fashioned with a spout, like the ileostomy there, then it's an ileostomy. It's a spout, basically. If it's a colostomy, the mucosa is flush with the skin, as in the second picture on the right there. The reason the ileostomy has got a spout is because the contents of the ileum are very irritant to the skin, so they fashion the stoma with a spout like that. So that's another way to tell what the stoma is, basically. If you can, have a good look at it. If you can see how many lumens the stoma has got, then great. If you can't, then don't worry about it, because sometimes it's quite difficult. So if you can see two holes, 2 lumens, it's a loop ileostomy or colostomy. If you can only see the one hole, it's an end colostomy. And look at the surrounding skin. Is it irritated? So is there any erythema or ulceration, etc. Next thing to do is look for any surrounding scars if you've not already noticed them, which you probably should have. Obviously they have a stoma, so they've had an operation. Find the scar basically. Ask them to cough. Is there an incisional hernia or a parastomal hernia? Make sense? That'll all take you about 10 seconds to do those 4 things. This slide just summarises everything I've already said. You can read through that in your own time. If you wanted to summarise the stoma itself at the end, there's an example summary you can all read. Oh yeah, I did this on my night shift last night, so I didn't get around to actually reading this. I apologise. If you want a summary, just read through the slides. Okay. That's pretty much it. Have you got any questions?
Can you just put the table back on? Thank you.
This is from a book called The Unofficial Guide to Passing OSCEs. I wrote the chapter, so I just took from there. So buy the book as well. I'll give you the link.
You can put the link on the
Can
site.
you?
Yeah.
It's a good book actually, not just helpful.
You know how you said that when you go through your examinations you don't talk through it? When you get to things like a stoma or a hernia,
Yeah.
do you explain that bit or do you wait?
But we didn't get GI examination. I'd probably not have said anything, to be honest. And then regretted it afterwards when they didn't let me summarise. But I didn't say anything and I did quite well in the OSCE, so I don't think you need to. But you guys decide, you know what you're going to do. Half of us said nothing and spoke to the patient, half of us did a running commentary. I don't know what you did, Sean.
Are you from Leeds?
Yeah,
Running commentary.
running
It-
commentary.
I guess it depends on your examiner as well, because some of them like to have the running commentary, so it's a good idea to practice both. And some of them find it really, really
Yeah.
irritating.
Yeah.
But I think in Leeds they do like the running commentary most of the time, but not always. Because for your more advanced exams, like your paces and things like that, you don't do the running commentary at all, you just do and then present. So it really depends on your examiner.
So would you ask them?
No. They don't say anything to you if you speak to them.
Okay.
But they will tell you if they want it. Like for me, I started not to without the commentary, but then he interjected and asked me, can you just explain what you're doing, please? And then I sometimes they do ask specifically.
I was planning on saying something, but nothing came out. So I just spoke to the patient. So, good luck, guys. I'm very sorry that's very short. Mine was the short part. The history part was supposed to be about 40 minutes. I hope it's been a little bit helpful to you, not just going over stuff you already know.